Good morning, everybody. So I'll be talking a little bit about the ocular and neurologic manifestations of Takayasu Arteritis. Takayasu Arteritis is also known as aortic arch syndrome or pulseless disease, which is a granulomatous inflammation of the aorta and its branches. In 1908, Dr. Mikito Takayasu published several articles on this curious fundus findings. So the signs and symptoms of this disease. The early symptoms are usually non-specific symptoms of visual complaints, malaise, headaches, night sweats, joint pains, and weight loss. There's usually a decrease in blood supply to the extremities with a decrease in limb pulses and a Raynaud's phenomenon. Patients may present with hypertension, stroke, or retinopathy. The complications of such a condition is morbidity, which depends on the severity of the vascular narrowing. The aorta dilation with heart valve abnormality leads to a decrease in blood flow to the extremities. Hypertension-related complications may include a stroke, intracranial hemorrhages, seizures, ischemia, retinopathy, and organ failure. The side effects may also be due to chronic steroid use. The 5-year and 10-year survival rates are 69% and 36% if there are 2 or more complications. The 5-year and 10-year survival rates are 100% and 96% if one or no complications. So the diagnosis of this condition depends on the American rheumatology criteria and angiographic-based categories or the Ishikawa clinical classification. Patients usually have reduced or absent pulses. The blood pressure might be increased. The imaging may show, the imaging which is usually done is angiography, MRI scans, chest x-rays, ultrasonography, and echocardiograms. A biopsy of the vessel may also be done. Laboratory results will include a CRP, full blood count and differential count, fibrinogen, albumin, and globulin. So the management usually, steroids are the first line of treatment, but these steroids need to be tapered. If steroids do not help, one can use cyclophosphamide and or methotrexate. Ocular neovascularization is usually treated with laser. Angioplasty is usually used to treat obstructive vascular lesions. Large vessel reconstructive surgery may be used by bypass grafting. There should be strict management of the cardiovascular risk factors. So in essence, it's a multidisciplinary approach. So case study 1, this is Ms. ZS, a 24-year-old black female who presented with a stroke, poor vision, and speech impairment. She gives a history of dizziness, headaches, and multiple fainting attacks and joint pains over the past 2 months. On ocular examination, her visual acuity was 6/9, 6/24, anterior chamber showed trace cells, the pupil reactions were sluggish, IOPs were 4 bilaterally, the fundus showed cottonwool spot, microaneurysm, and a congested disc bilaterally. On systemic examination, we weren't able to measure the blood pressure or pulses on the upper limbs, but the blood pressure on the cuff was 100/63 and the pulse was 88. The neurologic examination showed a right-sided stroke and aphasia. The head and neck examination showed no carotid pulses that were palpable, and the rest of the systemic examination were essentially normal. So on blood examinations, special investigations, we took bloods, and the full blood count showed an increase in white cell count. The CRP was 11.3, ESR 26. The kidneys, livers, and were normal. There was a typing error here. The lumbar puncture wasn't exactly normal because it showed an increase in intracranial pressure as well as an increase in CSF glucose levels. The chest X-ray was normal. The CT brain showed features of meningitis with increased intracranial pressure. The MRA showed features of large and medium-sized vessel vasculopathy with complete cutoff of the left major arteries and also stenosis of the right bronchocephalic trunk. The fluorescein angiogram showed a delay in transit from arm to retina. There was bilateral extensive capillary dropout with areas of microaneurysms and cottonwool spots. The complication that she had was steroid-induced cataracts, which we treated surgically, and she also presented with neovascularization of the retina, which we treated with pan-retinal photocoagulation. I assume in this day and age, one would also consider the use of anti-VEGF. The discs showed signs of ischemic anterior optic neuropathy. The patient is presently on methotrexate, aspirin, and prednisone, but she was also, because of her lumbar puncture findings, she was also treated for Koch's disease. Ms. CM is a 24-year-old black female. She presented with a 1-week history of being unable to speak and a sudden loss of vision in her left eye. Her past history was that of left-sided headaches, fever, and photophobia. On ocular examination, her visual acuity was 6.6 on the right and NLP on the left. Her anterior chambers showed trace cells on both sides. Her pupil was reactive on the right, but an APD on the left. Her intraocular pressures were 8 and 5, and a fundus finding on the right was normal, but on the left there was an optic atrophy and a cherry red spot. On systemic examination, we weren't able to measure the blood pressure or pulses on the upper limb, but were able to measure them on the lower limb. The blood pressure was 124/70, the pulse was 70 beats per minute. The neurologic examination showed stroke affecting Broca's area and resulting in aphasia. The head and neck examination showed that there was a right carotid bruit. The cardiac examination otherwise was normal, and the rest of the systemic examination normal. So on blood examination, the full blood count was normal with CRP of 4, ESR of 30. The liver and kidney functions were normal. The lumbar puncture was normal. Chest X-ray ECG was normal. The CT scan showed a left parietal gyriform lesion enhancing with contrast. The MRA showed a left internal carotid artery and left subclavian artery narrowing, which you can see in the first picture quite nicely. And the fluorescein angiogram showed a delay in arm to retina transit time with peripheral retinal AV anastomosis, as we can see on the third picture at the bottom. So the diagnosis of Takayasu arteritis was made, and the management was a multidisciplinary approach. So in conclusion, Takayasu's arteritis can manifest with systemic and ocular features of ischemia. Life-threatening complications are picked up on imaging and other investigations. A multidisciplinary approach is required in the management of this kind of disease. Medical treatment in the form of disease-modifying drugs can alter the course of the disease. Surgical interventions may also be required. But in spite of secondary procedures such as PRP or anti-VEGF use or cataract surgery, Takayasu's arteritis can progress and cause loss of vision and loss of the eye. Thank you for your attention.